And also you brought a very important point that we have to clearly distinguish radiation pneumonitis from ILD because the way you hold the drug, that you treat the pneumonitis and when can you resume, it's very different between the two. So if we don't distinguish the differences, we may be taking Enhertu too early for a patient. So I think it's important to also understand the nuances, and thankfully the presentation today was very helpful, I thought.
Absolutely. And it's really nice in the presentation. They really break down grade 1 interstitial lung disease versus grade 1 radiation pneumonitis. Of course, in the setting of grade 1 interstitial lung disease, you can hold therapy, treat with steroids for better part of 3 to 4 weeks, and then re-challenge with T-DXd. In the grade 2, in the ILD arm, if there's grade 2 symptomatic ILD, then we are no longer re-challenging with T-DXd. But if it's grade 2 pneumonitis, you can. So I think that's really interesting. And I also think it's going to be very, when we do get to a place where we've treated more and more patients with neoadjuvant and adjuvant T-DXd, ensuring that how this is categorized is very clear, so that if they do recur with metastatic disease, we still have the option of T-DXd if they did not have grade 2 ILD from the drug.
Right.
And that's going to be really tricky. And I think we're going to need to, work with within our groups to be able to differentiate this with our radiation oncologists and also bring in our pulmonary colleagues as needed.
Yeah, this is going to be a true multidisciplinary situation, right? Like it's a scenario where we need the expertise from everyone, even the radiologists, I think, trying to tease out and be more clear about where do you see the ground glass opacities, be specific about the location so we can make those right decisions for our patients. So I think we are all going to learn so much, as we start treating these patients and educate our colleagues about these nuances.
Absolutely. And having, high suspicion.
Exactly.
Right, and making certain that we're identifying, and I think this is where being able to monitor, particularly in the adjuvant setting, CT chest, non-contrasted CT chest, ILD protocols regularly during the adjuvant phase is going to be really critical.
Yeah, I think that's why, again, once we start to use this more broadly, having maybe an institutionalized protocol to follow may be much easier, like how we do echo every 3 months. It's built into our treatment plan. So even our nurses, they will not release the chemo, even if we forgot or our APPs forgot to order the echocardiogram, they make sure that it's there before they release the Herceptin. So I think the same way I'm thinking to implement something like that, maybe add the CT into the treatment protocol. That way it's there and we are all thinking about it proactively and not missing that
Absolutely.
milestone.
It was also interesting in the way that they ran the protocol for patients who did the sequential. They recommended a baseline CT scan after radiation, which I thought was really interesting, because what if there were changes in the lungs post-radiation that we weren't aware of, and then it gets attributed to T-DXd down the road. So having that baseline, and if it's sequential, if the choice is sequential, getting a new baseline, and then having, every 6 weeks during therapy. And I love the idea of having the beacon build, because like you said, there's so many different moving parts. We'd hate for that to get missed. Yeah, it's a great point to standardize.
Also, because many times when the patient is in the surveillance, in the adjuvant setting, they are maybe seeing our APPs, our advanced practitioners, and they may not be seeing us with each cycle. So I think, again, educating our own team, our nurses and our APPs is also very crucial now that we are going to start implement this.